So I'm happy to introduce Mary, who I got to learn about your program kind of through connections of different folks, and I was so inspired by your work. I really wanted to hear about it more. Thanks.
Hi, good morning. My contact information is, I think, on the last slide. I do have a bunch of business cards, so feel free to reach out if there are other questions. Just want to start out saying how honored I am to be here today. I know I'm a little bit of the outsider coming from San Mateo County, but a lot of the work that we do is similar, and so I'm happy to share our program with you today. So I'm the supervisor for our integrated medication-assisted treatment team, and what a nice segue, what great work you guys are all doing. So set this up really well. I'm with the County of San Mateo. I've been with San Mateo about 10 years. This program is just over 2 years old, so we're fairly new, which is what I love, because starting a new program, you get to create all these policies and get to set the tone of how you do what you do. But starting a new program, you have to set all these policies and set the tone of what you do, so it's a little overwhelming on both sides. Just to start out with, if you don't know, our former General Surgeon Vivek Murthy, look him up. He's one of my heroes in this field. He was recently on KQED Forum. He does such a great job advocating for our field. From a national perspective, he was relieved of his position with our new administration, which is catastrophic, not surprising. But he did the very first Surgeon General's report on addiction in America. And what he highlighted was some of these really impactful things, such as, if you look at the amount of Americans who have all cancers combined, there are still more people with diagnosed substance use disorders. What that means is not even counting the amount of people that have substance use disorders that are not diagnosed, which we know is monstrous. Obviously, there's a huge, $420 billion economic impact, looking at loss of jobs, loss of productivity, healthcare cost, incarceration, things like that. And only 10% get meaningful help. That's not to say that what we're all doing is not important work. It's to say we need to be trying different things to meet these folks where they are. And what he calls out in the report is there's he calls out the abundant amount of scientific data supporting the efficacy of medication-assisted treatment, MAT. And he calls out the need for us to be doing more of that. So this is all to set the tone for what my team is doing. For those of you that aren't familiar with MAT, essentially it's medications paired with behavioral therapies or counseling, right? So those two things together. You take medications for asthma, you take medications for diabetes. There are medications that help support addiction use disorders, right? Medications that reduce cravings for alcohol, for example, things like that. Some people don't know that's part of our elevator pitch when we're bedside in the emergency department. Hey, did you know that there are medications? You're getting medication for your hypertension, you're getting medication for asthma. Did you know there are medications that can help with alcohol use disorder, that can help monitor your cravings and help you into your process of recovery? So that's part of our elevator pitch. Where we came from is we did a pilot in behavioral health services in San Mateo County back in 2013. We worked with about 20 to 25 individuals, working specifically with the one medication, which is the long-acting injectable form of naltrexone, also known as Vivitrol. And what that medication does, it's an injection, it's an intramuscular injection into a sore spot, and it goes in once every 30 days. So you can imagine the folks that are homeless, folks that cannot get prescriptions filled and monitor and take medications on a daily basis. This is hugely helpful. And so we did for a year in 2013, 2014, drove around under bridges, vans, wherever, picked people up, brought them into our clinic, did health screenings, evaluation, connected them with different types of outpatient counseling, other types of recovery supports, brought them to RAP groups, and did the Vivitrol injection. And what we saw was dramatic improvements in engagement and dramatic reduction in use of emergency services. So that was with a small sample size, and our health plan, HPSM's health plan of San Mateo, they looked at this and said, oh, we like reduced emergency services, we liked healthcare savings, that sounds good. So in partnership with the health plan of San Mateo, we're very fortunate that we only have one healthcare provider, which I understand is a blessing and sometimes not. But with the health plan of San Mateo, our county behavioral health recovery services, which is where I'm part of, and SMMC is our San Mateo Medical Center. So that's our county general hospital that operates hospitals and clinics. So this partnership developed, and certainly in my time and in our director's time, he said he hasn't really seen a partnership like this before. So when you have something like that, it gets a lot of attention and a lot of eyes on it. So we were kind of highly scrutinized in our first year or two, which I like because I know we're doing great work, so that didn't bother me. So we started officially June in 2015. June 1st was our first day in the emergency department. We were given an office space in the emergency department. Those of you that work in hospital system know how valuable that is, right? So we don't take that lightly. We treasure the space. We're very respectful. And it's gotten to the place now where the staff love having us there, which is really cool. And you know, if we're all at a training or a meeting or we're transporting or doing something, we get people knocking at our door going, "Where's I'm at? Where's I'm at? How come you're not here? How come you're not here?" I'll get calls on my phone. "How come you're not here?" "We'll be back in 20 minutes, don't worry." So it's great. It's created the sense of, you know, in the back of my mind, I'm going, we didn't exist 2 years ago, and you know, you can't function if we're not there for 20 minutes. Like, so it's an interesting relationship that we've developed. Real briefly, our goal in 2015 when we started this, it's really hard to see this little red dot, right? So I'm going to jump over here. We have a clinic, this is new, and us, right? So I'm going to be talking about the IMAT team, but our goal really was to take medication-assisted treatment and push it out to the whole system. We did not want to be gatekeepers for MAT, so we do a lot of outreach psychoeducation. We've done a number of injection trainings to teach nurses how to do the injections so that anybody at whether they're at a mental health clinic or a primary care clinic, that they can be doing MAT as well. This is us. We did a little retreat, some staff building collaboration, just so you can put a face with some of these people. And these are the services that we rolled out. So mostly I'll be talking about the SMMC, which is the San Mateo Medical Center. We also have 2 case managers that are field-based that are in the field. So they 6 days a week now, they're driving around, they're visiting people in jails, they're working with shelters, working with all of our substance use providers in the community, seeking referrals. Mostly they're working with people who have any kind of law enforcement involvement. So we get referrals. There's this one police officer, and he covers the beat in downtown San Mateo, and we'll get texts from him. "Show up at the corner of 3rd and B." We're like, okay. And so we show up at the corner of 3rd and B Street, and there's Officer Johnson, and he's, you know, grabbing my case manager saying, "Okay, there's this guy here, and he hangs out, but I need you to go," you know. And our agendas are very different, right? But we've developed collaboration with law enforcement to absolutely, we will use motivation interviewing, we will go assess stage of change, we will go engage, offer services. Maybe today it's just providing a cup of coffee or a meal or some dry socks, or right? But we're doing that outreach and engagement. At best, we're putting them on our radar, so we start that conversation of engagement. We did open a MAT clinic. So this is one of our contracted providers, Health Right 360. They opened a brand new physical space, which is really hard to do when you're trying to get it licensed for MAT and primary care and other things. They do basic primary care. They have case manager. They have MD, nurse support, both who have their X waiver. And they're doing all of our prescribing and injections at that clinic. So we take our clients to this clinic, and they're open 5 days a week. We expanded our detox beds, so BHRS, with this funding in this program, we purchased the full capacity of our detox, so we now get priority access, which doesn't mean we get an open bed every day. It still means we usually have to wait a little bit, but when it's us calling, you know, we have like the back numbers and we have the relationships and a good collaboration, so we can usually get someone into detox within 24 to 36 hours, sometimes 48 hours if it's a rainy, cold night. And then we have a whole nother group of case managers, 4 that are embedded in primary care clinics. So if you're at a primary care clinic and your doctor identifies alcohol use disorder, opiate use disorder, you'll be referred to an IMAT case manager there to help transition. The team that gets the most referrals and is the busiest is the folks stationed at the emergency department. And that says 3 case managers. We're now part of whole person care too, which is why I was so interested to hear what you're all talking about. We now have 5, so we got expanded 2 more case managers for our team under whole person care. So they're at the emergency department 7 days a week in this little treasured office space that we have. We get knocks on the door, we get doctors walking in, we get clients knocking on the windows. So if you walk into the emergency department at San Mateo Medical Center, you have the triage hallway to your left, you have the psychiatric emergency to your right, and you have IMAT directly in front of you. And it's a little discreet, we have this big glass off door, but I mean, this week, literally, we've had 3 people just walk in and knock on our door because they were at the emergency department at one time or another, and they know that we're there. That, to me, is just fantastic. It's fantastic. People know who we are and what we do. It's almost as flattering as when we get clients who get into triage, and they tell the triage nurse, don't send IMAT. We're like, okay, so you know that we're here, you know what we do, and you're not ready to talk. Got it, not a problem. So my team, we handle rejection very well. We get told no all day long, and that's totally fine. So that's the bulk of what we do. To date, so we started in June of 2015. As of our data last week, we had 3,570-something referrals. We get between 20 and 30 referrals a week, largely from the ED, also from psych emergencies, some from the community, from law enforcement, courts, probation officers, things like that. Much, much, much less from the latter, mostly from the emergency department. On any given day in the emergency department, we're seeing I'd say minimum 2 to 3 people, maximum 8 to 10. So it's busy, and you can imagine these are all people coming in intoxicated in crisis, and they're calling us to do what we do, and this is who we serve. Yeah.
But the embedded in primary care, if you identify someone with MIT, are you ever trying to put an MIT clinic, or do you get
Great question. So we have in the beginning, we had a dedicated addictionologist with BHRS that would consult with primary care physicians in the primary care clinics, and if the PC was not comfortable, or they were hesitant, or looks like it maybe wasn't going to happen, our doc would go to the clinic and start MAT for them. We started mostly with alcohol use disorder, and it's only recent that we're doing more opioid use disorder. So it was easier for her to manage that way. But now the relationships with the primary care clinics are so strong. There's 4 main ones that we work with, that the primary care docs they're prescribing gabapentin, they're prescribing naltrexone,
those primary care providers take this one and use it?
the primary care docs or the nurses are identifying their patients, and they're connecting it with our behavioral case managers to say, can you maybe we do an evaluation for outpatient substance use treatment. So they're prescribing MAT, and then they're either using our physician to consult, or they're using our case manager staff to link them with other services. They might need shelter, they might need residential treatment, so we do evaluations and link people with treatment. Great question. Yeah, please, I'm talking fast, 1, because I'm from the East Coast and that's what I do, but 2, because I'm on a time limit. Okay, so we see people with chronic problematic alcohol use. That was the initial pilot that we started with, because alcohol was the #1 drug of choice we saw coming from the emergency department. As you recall, Dr. Murthy also identified alcohol as the #1 driver of costs for healthcare under substance use disorders and the economic impact, high utilization, law enforcement. All of our folks, because we were funded by Health Plan of San Mateo, I say we're because now we're under whole person care pilot, but we'll still eventually be funded by Health Plan. They had to be members or eligible, so we do have a bucket of money in BHRS if someone's undocumented, that we link them with services, so we don't turn anybody away. We still take them in, and it might just be we see them at a different clinic with a different doc. We do work with people who are motivated to stop or reduce their use. If someone's in pre-contemplation, we keep them in our outreach bucket, and then connected to services, we basically do psychoeducation for if they have an existing team, we're not looking to rip them apart from their team, so we reach out to their doctors. The case managers are really the biggest, strongest component of MAT. The work that these guys do, 7 days a week, 19 hours a day, I mean, it's such a big part of this work, I can't stress that enough. I'm not going to go into each of these areas, you can read about them yourself, but the outreach, transporting someone to an appointment just to make sure that they show up, it's hugely important. Okay, really quickly, I'm not a huge numbers person, but this was our data from our first year. What we saw when we looked at the individuals who were engaging in medication-assisted treatment, we started with we could look for naltrexone, the long-acting naltrexone, in our data system, and we could have recorded that data. So we pulled out 73 individuals who were just receiving that one medication. And 6 months before our intervention and 6 months after, there was a 55% reduction in their overall healthcare costs. We saw 62% reduction in how many times they used the ED, 61% reduction in being admitted to, so people that did go to the ED, they were reduced their inpatient stays by 61%. And what we wanted to see was that they started utilizing outpatient services. Right. So, yay. And this mirrored the pilot we did in 2013 as well. Our treatment completion rates, so when we worked with an individual, what this is essentially highlighting is that people in treatment with MAT are much more successful, at drastic rates more successful than county and state data. I won't go into the slide for this. Just kind of shows that the average healthcare cost, the longer someone's engaged. So we don't put a time limit. We don't say, yeah, you can have this medication for 6 months or a year. We just keep reevaluating if it's needed, and if it's effective and helpful, we keep doing it. Next steps, we are expanding to opioid use disorders. We've been doing that for about a year, but we've been kind of doing it on the down low because we weren't supposed to be telling people broadly that we're doing it, for whatever reason, because our system wasn't ready. So we're getting ready, but you guys know the issue. It's on the front of the newspapers every single day. So we've had 4 referrals already this week. We had 2 last week. So in the last 6 months, we're starting to ramp up what we're doing, and we're filling spots, which is great. We are also part of an organized delivery system for the drug Medi-Cal waiver. So my case managers are all trained in the ASAM evaluation, so we can help place and link people into residential. It's just taking that barrier away for people. And we're also under whole person care pilot. We kind of function as our own unit, but we talk with everybody, and I attend lots of whole person care meetings. And we talk with everybody in whole person care, and we just essentially link with the care navigators and are part of that system. We're a resource for their system. So, and to leave you with a quote from Dr. Vivek Murthy, that the most important thing is we have to change attitudes towards addiction and get people into treatment. Addiction is not a disease of it's a disease of the brain, not a character flaw. On your one-pagers, also some more of the challenges. Many people mentioned these already. My team uses 5 electronic health record systems. 5. Yes, we have Avatar, which we document in. The emergency department has its own system, which we check. The prescribers have another one which we check. I mean, so it's a lot. So that's also part of our whole person care issue. Changing addiction. There's so many antiquated notions about using medication in addiction. I mean, this is the future of where it's going. And so we just need people to get on board. And so we do a lot of psycho-ed, meeting practitioners where they are, because we have lots of practitioners who are in pre-contemplation about medications for addiction. And, we do the same MI approaches with the docs around how to prescribe and how to use, and that's totally fine. So that's some of the challenges. Do we have time for questions? Or are you?
Yes. Okay. Any questions for Mary?
What is the caseload size that you're typically carrying?
That's a great question. So my guys have usually around 30. So, and when we do case checks twice a month, and I'd say the average is probably 25, the max is about 30, and when we look at the cases, we divide it into about a third are in outreach. Like, they showed up, we did a bedside in the triage hall, and this person is likely never gonna call us, but we keep them open for a couple weeks in case they do, and we do some outreach. So those are like the low contact. We have about a third that are in action and are kind of almost self-sufficient, taking care of themselves, but we keep them open. And then we keep about a third on the caseload we're really drumming up, helping moving someone from pre-contemplation to contemplation.
I just wanted to follow up. And you had mentioned that there is priority access, but there are some challenges with that. What are the strategies that you use while you're waiting for the priority access? Great question.
So we have a sobering station, which is also a licensed 23-hour facility. And so I actually just hired one of their staff. So we basically take somebody from the emergency. The typical flow is we meet them in the emergency department, they get medically cleared, we help them go to the pharmacy in the hospital, get their prescriptions, we get all the discharge paperwork, and we take them to our sobering station. They stay at the sobering station. They can stay up to 18 hours roughly, but our they're really helpful with us, where they do like a discharge, walk around the block, and then readmit if we can't get that detox bed. They're just amazing. And they always have capacity. So we work with them, and then we get someone into detox. With our priority access with detox, we've kept someone there up to 3 weeks before, where usually it's a 3 to 5 day facility. We've had people there. If we know we're waiting on a residential bed, or it's some kind of priority population or something that we can make justify cause for them staying longer, then they can be there. We've had someone there almost a month, a little over 3 weeks. So. We had a gentleman who, in a 12-month period, because we get all the lists of, the high utilizer stuff from our health plan in the hospital, and he had 37 ED visits. And, so it's someone we knew. This was one of the guys who was like, don't even bother giving me your business card. It's a waste, today's not. We just had this common, not today. And that was his dialogue with the team, And he's seeing different case managers on different shifts. And over the course of a year, we had logged 37 episodes. And I think we had talked to him 30 times, but he had been at the ED 37 times. And it literally was his 38th visit to the ED, and he looked at this one case manager, and he was like, today's the day. We were like, oh my God, okay, stop the earth, what do we do? So we did the flow where we got him into the sobering station. I think he was one of the guys, he stayed there maybe a day or two. We got him in bed at detox. And we got him into a residential treatment program. He did 90 days at a residential treatment program, started the Vivitrol injections. I think he did 11 Vivitrol injections before he and the doctor worked out that, I'm stable. He was in SLE, supported recovery residence, and he decided he was able to go down to the oral pill. He wanted to take the oral medication, so they switched the medication. It's much less costly, is one. Not that he had to pay that; it was covered by Medi-Cal, but just from his preference. And so he started managing naltrexone, and then 3 months later, he actually became employed by the county because this is a guy who actually, he was homeless for 11 years in the streets of East Palo Alto. He had traumatic brain injury from being assaulted on the streets, but he had been a county employee 20 years before and then became homeless. And so it was a really cool success story. We actually took him back to the emergency department at one point when he was very close to completing his residential program. And we do a shift huddle with the ED staff every day. We do it twice a day. And at the 7 a.m. shift huddle, we had him speak. And it was so cool because the staff got wind that he was coming to talk. So the night shift actually stayed when they're usually out the door very first thing, right? The night shift stayed and the day shift was there. And I've never seen the nurse station so busy, and everyone was there listening to him. And he just very humbly expressed his gratitude for the work that they had done in the team. And, some of the nurses came up to our staff and was just like, we thought he was dead. We thought this guy died, right? And so to hear that he had, at that point he had, I think it was 2.5, 3 months of sobriety, and so it was pretty cool.
I think one more, and then
That there was a significant difference between the success rate between residential and outpatient.
Yeah.
Can you talk a little about that? Are there a number of outpatient members in outpatient that should be in residential? Or is it?
So we started our ODS implementation in February. So we went live February 1st. So part of it is that residential treatment is limited to 2 episodes per year, right? I think our numbers are really high with residential because we do an awful lot of screening and motivation interviewing and making sure that when we're referring someone to placement, it's the right place at the right time for them. So we actually, if someone's seeking residential treatment, there are plenty of times where we actually don't link them with residential treatment because we're fearful that it may not be the right place if they're not fully motivated for abstinence. And we do the same with outpatient. Outpatient in general, historically, if you look at data locally, statewide, nationwide, it's always lower, the retention rates. I think our numbers are higher because we have case managers pick them up, make sure they're attending meetings. We have case managers attending their graduation ceremonies and helping plan and transition, discharge planning. So we're part of their care every step of the way. And so I think that is why those numbers are different and higher.
Thank you. Mm-hmm. Thank you so much. Awesome. Thank you.